All right, welcome. We are here to talk about some of the interventional pieces that we use in the Cath lab. So let's get started. So we have balloons to start off with, the procedures we do with balloons are called a PTCA, or percutaneous transluminal coronary angioplasty, or a POBA, plain old balloon angioplasty. It is used for dilating vessels, opening blockages, delivering stents. There's rapid exchange, which is time-saving, and there's only a guide wire that goes through a short section, compared to the over-the-wire balloons where the guide wire will actually track along the full length of the catheter. It's easier to see those kind of hands-on, and we've got some practice equipment that we can use that's above the cabinets in Lab 3. Now we've got non-compliant balloons, which are high-pressure balloons made of polyester or nylon to expand to a specific diameter. Our semi-compliant balloons, which are mid-pressure, made of PBEX, flexible and more compliant than non-compliant, and the compliant ones, which are made of polyurethane or silicone. They're inflated by volume and pressure. So balloons, we have the inflation and deflation. It's that time that it takes to inflate and deflate a balloon. There's the trackability we want to focus on, which is the ability to reach that site that needs to be angioplastied. And you'll hear that a lot, especially in CTOs, where it's very tortuous and tight to get to our lesions. And then the insertion profile, which is the amount of space that's actually needed for that balloon to be inserted through. So our non-compliant balloons are used in the dilatation of stenotic coronary arteries or bypass grafts to improve myocardial perfusion. They're indicated in dilating after stent placements, bare metal or drug-eluting. Now typically we are just using drug-eluting stents here, but in case that changes, we can use them after bare metal as well. It is not indicated in unprotected left main coronary artery or coronary spasm without stenosis, but ultimately it is up to the physician's discretion. Now for IVUS is intravascular ultrasound. We use this a lot. It's one of the gold standards for placing stents and determining that we have optimized the stent placement. It's used to assess the minimum lumen area, or MLA, to choose the accurate stent and balloon sizes during PCI, including length, diameter, and expansion. Using this reduces the risk of death, myocardial infarction, stent thrombosis, and repeat vascularization. We can evaluate a stent for underexpansion, malapposition, edge dissections, plaque shift, and coronary spasm. And we have two types of IVUS here. We use Boston Scientific and Volcano. There are other options as well, but those are the ones that we are using. Fractional flow reserve. Oftentimes you're going to hear this called FFR. So this will determine the presence and extent of myocardial ischemia due to atherosclerotic plaque and identify the need for revascularization. It is the gold standard for detecting ischemia inducing coronary stenosis. It is superior to angiography alone, and the ratio of distal to proximal pressures of the lesion under maximum hyperemia is what gives us our value. So the FFR value of 0.8 is significant for ischemia, suggesting 90% accuracy. So it's almost like we're doing an intra-procedure stress test. We give adenosine, and our wire takes these values and converts it into a decimal to identify how stenotic this lesion is. And since we were doing FFR and using adenosine for such a long time, a new process came out where we can actually find a very similar value with IFR. So it's doing the exact same thing. I'm putting the wire down the vessel and measuring that pressure beyond the lesion and proximal to the lesion and obtaining a value. And so the IFR is the value without adenosine, and you're looking for a value of 0.89 or less, and that will be a positive indication that we'll need to fix that vessel. Laser is another tool that we use. We have coronary and peripheral laser. The coronary laser is a rapid exchange device. The sizes are 0.9 millimeters to 2.0, and they go over an 014 wire. Typically, we're going to be using the 0.9 laser. It's used for treatment of in-stent restenosis, total occlusions, occluded SVGs or vein grafts, and osteal lesions. There's adjustability to pulses and fluency, and it'll shut off automatically after 10 seconds. Once it shuts off, you've just got to wait for a second. It'll beep at you, and then you can start up the lasing again. While we are lasing, we need to be flushing with saline throughout the whole treatment time. And that just makes sure that that laser, as it gets hot, it doesn't get too hot. It kind of keeps that lubricated. It is contraindicated in unprotected left main lesions, acute bends, bifurcations, and if they're a poor candidate for bypass surgery. And then below, I'll let you look, I'll put it in the comments, this little link, just kind of a quick overview of laser from their website itself. Next we have Rotopro, and so this is a diamond tip burr. It's used to ablate calcium in coronary arteries and the treatment of moderate to severe calcium. It preserves the elastic tissue of vessel walls. You get feedback when you are drilling. It's tactile, auditory, and visual. Rotoglide is used as a lubricant during the procedure, and the burr at the tip rotates at high speeds and should not come in contact with fabric or tissue. So like anything on the sterile field, all those towels, you really want to keep that off those towels if you can. And you want to analyze the system if resistance occurs. The indications are single vessel coronary artery disease with stenosis that can be passed with a guide wire, multi-vessel disease in which the physician feels the patient is stable, patients with previous PTCA with restenosis. However, it may damage the stent if it is in the stent, the rotablator itself. And then native vessel atherosclerosis that is less than 25 millimeters in length. Contraindications include occlusions in which a guide wire will not pass, the last remaining vessel with a compromised LV function, saphenous vein grafts, thrombus treatment within the last 2 weeks, significant dissection, and Rotoglide if the patient has an allergy to eggs, because there is an egg substance in the Rotoglide itself. CSI is another kind of drilling tool that we have, but instead of a rotational atherectomy, this is an orbital atherectomy. So it will remove calcium in coronary and peripheral arteries for facilitating stent delivery. It's a 1.25 millimeter, not centimeter, eccentrically mounted diamond-coated crown. It reduces calcium and allows healthy tissue to flex away. It has bidirectional sanding and creates particles smaller than a red blood cell. We use Viper Glide for the CSI, and it's used as a lubricant for this device to prevent friction. And for this and Rotablator, we want to monitor for bradycardia due to that release of adenosine as we're drilling. It is contraindicated when the wire cannot pass, if the lesion is in a bypass graft or stent, if there's thrombus present, and if only one vessel is open, if there's a significant dissection at the treatment time, women who are pregnant, and children. So the Impella is a pump. It pumps blood from the left ventricle to the ascending aorta. We've got the Impella CP, which is inserted through the femoral artery. The Impella 5.0 is inserted through an axillary cut down by the surgical team. The Impella RP is actually pumping blood from the right ventricle into the pulmonary arteries, and so that one will support the right ventricle, whereas the other two support the left ventricle. Its indications for use are protected PCI, ventricular support during high-risk PCI procedures, either elective or emergent, less than 6 hours of use. And it may reduce peri and post-procedural adverse events, indicated in cardiac shock, temporary ventricular support for up to 6 days following the MI, cardiomyopathy, LV failure, or failure of pressors or inotropes. It's intended to reduce the workload of the ventricle and perfuse the organs as well as the coronary arteries. It is contraindicated in mechanical aortic valves, the presence of LV thrombus, severe aortic stenosis, ASD, LV rupture, and cardiac tamponade. Balloon pump is an alternative to that, where the balloon catheter is placed in the descending aorta percutaneously through the femoral artery, which attaches to the console to inflate during diastole and deflating during systole. And so that diastolic inflation pushes that blood back to the coronary arteries, where it would otherwise be flowing down towards the legs. And that systolic deflation will decrease blood pressure in the aorta, resulting in decreased aortic end diastolic pressure and afterload, and an increase in cardiac output. Chest electrodes must be applied as the R wave on the EKG is the trigger source to prompt the balloon to inflate and deflate. The heparin bolus may be prescribed by the physician, and a peripheral heparin drip will be started. Heparin is also often used for arterial lumen patency, so we'll connect that to a pressure bag on the balloon pump itself. It's important to identify that the waveforms are yielding optimal results, inter-procedure and post-procedure, so we can see our normal inflation in this picture here, where at the end of our aortic pressure, the end diastolic pressure is decreased just in time for that assisted peak systolic pressure. And so we can see here the early inflation and the early deflation, as well as late inflation and late deflation. And so here's angiojet. We've got a pharmacomechanical peripheral thrombectomy device with active inspiration and power pulse lytic therapy for venous and arterial clot. It is quick restoration of blood, symptom improvement. Pressurized saline is sent through a catheter tip, which creates a low pressure zone, yielding a vacuum effect with the thrombus. Penumbra is another thrombectomy device used for neurovascular, peripheral, and coronary revascularization and thrombectomy. For coronary, we use the Cath 5, used mostly in STEMIs for that new acute clot. Peripheral, we have the continuous aspiration mechanical thrombectomy system designed to remove clot from arteries and veins. And neurovascular uses it as well for revascularization for acute ischemic stroke, secondary to intracranial large vessel occlusion. Next, we've got our Zoll targeted temperature management, or our cooling catheter. It's used after ROSC following a cardiac arrest. It will maintain temperature between 32 and 36 degrees Celsius for at least 24 hours. Has been shown to improve survival and neurologic outcomes. It's contraindicated in nobody, so anybody can get this. We want to have a temperature sensing Foley to confirm that temperature, and then we're rewarming. The electrolyte imbalances, acidosis, temperature shifts, and hypovolemic shock may occur. So the Zoll combines targeted temperature management with a central venous catheter. It'll circulate temperature monitored saline through the closed loop balloon on the catheter, which either warms or cools the patient, and can be inserted via femoral, subclavian, or IJ. Typically, we are inserting it femorally, I would say primarily. Our Lucas is our mechanical CPR machine. So it's a life-sustaining circulation provided by uninterrupted high-quality chest compressions. It standardizes chest compressions by preventing rescuer fatigue and rescuer variability. There's more blood flow available to go to the brain and the heart, increased end-tidal CO2, less interruptions, and opportunity to defibrillate during compressions, and also decreased radiation exposure to the cath lab staff. So if you think about it, we do have to get creative with our angles of our C-arm. However, it does give one person an opportunity to be running around helping out in that situation instead of manning compressions. ECOS is our ultrasonic clot buster for PEs. It has acoustic pulse thrombolysis and makes fibrin porous so the drug can deeply penetrate the clot for faster dissolution, enhancing clinical outcomes and increasing clot removal. It decreases the risk for bleeding and decreases risk for vessel damage due to targeting the thrombus with the drugs. It's 4 times less the dose than compared to systemic administration, and it's the only device approved by the FDA for treatment of PE. It improves RV function and PA pressures by reinstating flow. The drugs used are TPA. We do heparin to the side port of the sheath, and there's going to be another port that says coolant, and saline goes to that. Inari is another one we started using more recently. for venous thrombectomy. It's used for old and new clot, more recently used in PE clot removal for more instant results and diminishing the need for systemic antithrombotics. That cage will open up and pull out clot mechanically. CTOs, or chronic total occlusions, are another procedure that we do. It's for complete or almost complete blockage of a coronary artery that has been present for 30 days or more and caused by a buildup of atherosclerotic plaque. There's an individualized treatment plan for each patient because everybody is really different and different collaterals form for each of these people. The risk factors for a CTO are smoking, previous heart attack or CTO, family history of CAD, high cholesterol, postmenopausal, taking contraceptives while smoking, overweight, diabetic, hypertension, and sedentary lifestyle. Its effective wiring is the key to success in these procedures. We can go antegrade, retrograde, dissection, and reentry approaches. So depending on where we're looking at the blockage, we can see in both of those images on the right that there are some shorter sections, and eventually that wire goes all the way through in image B. It's often involving more invasive equipment such as IVUS, laser, rotoblator, and Impella, as these are some of the more complex procedures that we do. So here's a little bit of an algorithm on how they use wire escalation by kind of identifying that proximal cap, if it is ambiguous or defined, defining if that's a good target, and as well as the lesion length. And so they kind of go through this algorithm to decide which wires they're going to use and which way they're going to go. Alcohol septal ablations are procedures we don't do very often, but when we do, they're a pretty big deal. So these are a minimally invasive way to treat hypertrophic obstructive cardiomyopathy, so that overgrowth of that septum. So we inject absolute alcohol through a glass syringe into the septal branch to induce a controlled infarction in the hypertrophied septum. Alcohol has the necrotic effects on tissue and should be handled carefully, requiring multiple glove changes throughout the procedure. HOCM patients have an outflow obstruction of the left ventricle, creating a gradient of 30 millimeters or more between the left ventricle and the aortic pressure, so a 25 to 30% outflow obstruction. Echocardio is used at bedside during the procedure. Often it's a TE because we can get a little bit more invasive images that way. And 10% of these patients will need a pacemaker due to complete heart block after alcohol septal ablation. HOCM is a genetic cardiomyopathy unexplained by any other disease, ranging from asymptomatic to severe, with an annual mortality rate of 1% per year. Cardiac MRI can be used to evaluate the effectiveness and LV remodeling. The procedural steps for this are arterial access being obtained, reevaluating the LV and AO gradient, and it's going to look very similar to aortic stenosis on your waveform changes, but that gradient can actually be seen across the ventricle itself. There is venous access for a potential need for a temporary pacemaker. We're going to cannulate the left coronary artery and wire that first septal branch. An over-the-wire balloon is placed in the septal branch and expanded, and we want to observe the gradient at this time as it may reveal a reduction, yielding an optimal choice for that septal ablation. Contrast is injected through the over-the-wire balloon in that septal branch to determine the occlusivity from the LAD and observing for flow to the LV. We don't want that septal branch to reach all the way into the LV because that alcohol that we'll be injecting will go all the way through that way as well. So once we determine that's a good spot, we can inject alcohol through that still inflated over-the-wire balloon. Some complications here are LAD dissection, coronary artery spasm, cardiac tamponade, cardiogenic shock, PE, stroke, disruption of conduction system requiring a permanent pacemaker, and mortality. Our PFO closures. So patent foramina valley is a residual element of fetal circulation, which increases your risk for stroke. So we'll go in and kind of put in one of these occluder devices we can see here. And that is all I got for you.